And like half the stuff that they're saying on here, like into the ultrasound podcast, the resuscitation podcast, they'll walk you through it. They'll share the pictures of these cases. They'll share the lab numbers on these tutorials, and it takes me 5 minutes to get through, and we're sending almost one day.
So what do I need to make a Twitter thing?
Twitter account, just message me on our thread. Just message on our thread your username, and then at the end of the week I'll add in the ones.
All right. So now we're going to go over airway management, which is completely different from the Motivate Learn. All right. So why do we intubate? We intubate basically for it's generally 3 reasons. You could argue that it's for: one is inability to ventilate, one is inability to oxygenate, another is they can't protect their airway, meaning they're altered or they're vomiting or whatever other reason. And then sometimes it's just for optimal patient management, right? Like I had a guy who was in cardiogenic shock. I probably could have got him by on bypass, but he had a CP impella on his groin. He had to lay flat. You can't set him up, right? If you set him up or he moves, he's going to displace the impella and die. So in that instance, like for his best interest, you intubate him, right? That way the impella is going to stay in for a couple of days as you wait for his heart to recover, and then you can extubate him, and he doesn't die. So sometimes there's other reasons other than failure to oxygenate, failure to ventilate, and inability to protect an airway that you would intubate somebody for. Sometimes it's also like anticipated care, right? The agitated patient who's incredibly septic or something like that is wilding out and ripping out IVs. Sometimes you just have to intubate them, to sedate them, to give them the care that they need, right? It just happens. It's not as common as the other ones, but it happens, right? And so how do we intubate? So we can either do a rapid sequence intubation, which is most commonly what we're going to be doing. There's times when you would do delayed or awake intubation. Delayed intubation is a little bit different than awake intubation. We'll go over that at a later point in time. For right now, we're just going to focus on rapid sequence. So we generally do rapid sequence because we want to maximize our chances of first pass attempts and minimize the time to intubation. There are always risks with any intubation. They're mainly aspiration, hypotension, and esophageal intubation, right? And the number of times that we have to go back in, the number of failed attempts we have, each one of those comes with a higher risk of complications. So RSI is generally recommended in most settings because it's going to give you the best chance of first pass success, right? Contraindications to RSI are all relative. The most common contraindications are resuscitate before you intubate, meaning if the patient's got a blood pressure of 70/40 and you're reaching for the ET tube and you don't have a vasopressor in the room, it's going to be a clean kill. Undoubted, it's going to be a clean kill. That patient has got a code the second you push those meds, right? So if they need fluid resuscitation or they need to be put on like 60 of peripheral levofed to get them an adequate blood pressure before you put the tube in, go for it. The other one is when you look at this patient and you're like, holy crap, you were an airway nightmare. Like that is a contraindication to RSI. So how do we predict a difficult airway, right? There's all this like lemons and moans and this and that. And I think about it more like big fat biker man, right? If you got a big fat guy with a short neck that's all furred out with a ton of beards where you can't get a bag valve mask on him, like this is the guy when I walk in the room and he's like hypoxic and sat in and like chugging away on BiPAP, this is the guy I'm looking at being like, maybe we should call anesthesia, right? Like, and Mike Bonk's got BiPAP man, so I got big fat biker man. So Michael talked about BiPAP man at a different point in time, but like this is the guy when I walk in the room, I'm terrified of, right? That's not to say why we end up having difficult tubes is when you see a little tiny old lady and you're like, well, this is going to be the easiest intubation in the world. And then she's super duper anterior, right? Our failure to predict a difficult airway sets us up for failure, right? So the answer to that is, in general, anticipate every airway like it's going to be a disaster. And that way you have your 8.0 tube, you have your glide scope, whether you're going to use direct versus video, you've got a bougie and you've got a couple other sizes ET tubes down and you've got an Allen leg. And it doesn't have to be that they're right at your bedside, but they need to be out of the box on a table next to you so that if you say LMA, everybody knows where they're going. They're not having to run out of the room to grab the box, to bring the box back in to open it up, right? You lay it all out because you've already cracked the box when you went for it. So it's not like you're doing anything. You're just laying out what you anticipate you could need should you develop a difficult airway. So everybody will talk about the 6 Ps. I can't remember. It's a dumpster fire of information. Like I cannot stand mnemonics that are just 6 Ps or 5 Ps or 10 Ms because you're never going to remember what they are or in what order. But if you really have to, you must look at the patient. Like, is this going to be a difficult airway? You have to prepare and prep the patient and position the patient, right? Positioning is clutch in any procedure, and especially in intubations, right? If the patient's really far down in the bed or on their side or this or that, and then you're pushing the meds, and then you're gonna have to readjust them, like you're setting yourself up for a disaster, right? Get the patient in the position that you need. You have to have a plan. So if it looks like you're the only guy who's gonna intubate big fat biker man, right? You're gonna say, we're leaving him on BiPAP. We're gonna push the meds with him on BiPAP. We're gonna pull him off of BiPAP, and then we're gonna look. I've already prepped the necks. If I fail this and this, we're cutting the neck, right? You have to voice your plan to the other people in the room, because one, you say it out loud, and two, you're less likely to not do it because you've told everybody the plan. And when you deviate from that plan, people are gonna be like, oh, I thought we were gonna do this, and it holds you accountable, right? Your paralytic of choice, make sure you have pressors in the room and be generous with your post-intubation sedation, right? So medications, there's a ton of them. The only ones that you really need to know are etomidate and ketamine for induction agents. There's some stuff out there that now etomidate is worse than ketamine. The answer to that is either one is fine. Either one is fine. They've ran a trial about it. They've done multiple other things about it. They're in general equivalent. That's my interpretation of the literature. They're equivalent. So etomidate is pretty easy to judge because it's 0.1 mg per kg. So if you walk in the room and you say, how much does the patient weigh? And they say 100 kilograms, you just divide by 3. I want 30 of etomidate. If they're 120 kilograms, you divide by 3, you say, I want 40 of etomidate, right? As the patient's blood pressure is on the lower end, you may not give that full dose, right? And even with ketamine, it's like 1 to 2 mg per kg. So generally I'll tell them to pull up 2 mg per kg, and I'll tell them to give half. If the patient's not good enough, I'll tell them to give like another like half of what's in there. So you're dosing it by like half, and then you'll get up to the full dose. And then the only other ones you need to know on this list are rocuronium and succinylcholine. So sucks for a reason. I only use it if the patient's seizing. Otherwise, it's because it's 1.5 mg per kg. So you're making the math harder on yourself. Whereas rocuronium is basically 1 mg per kg. Whatever their weight is, and that's what it goes. Rock comes in 50 milligram vials. So it's generally either I want 1 vial or 2 vials, right? So it makes the math is easier, and it lasts longer, and it works faster-ish. The only time I ever use succinylcholine is in the seizing patient. So then should you ramp the patient? Should you put the roll underneath the patient? None of that really matters. You just need to get them in the sniffer position, meaning that you got to get their head forward so that their ears align with their sternum, right? Because that's how you're going to get the view of the airway. So if you're looking and you don't adjust the patient, when you go in to look in their mouth, you're basically looking at the back part of their throat, right? If you get their head up and their chin forward and the ears are in line with the sternum, now when you go in and you're looking at the vocal cords, right? So what has always been tended to be my practice is I go in with the blade and then I'll put my right hand underneath the patient's head to help lift them up into that sniffer position. You can try and put things behind their shoulders or behind their head to get them in that position. I've never actually found that to be incredibly helpful. It's generally go in with your hand, lift up, and put your right hand underneath their head to like cradle their occiput to get you where you need to go. And once you're there and you've got them in that position, when you move your right hand to let go, you're holding all that weight with your left hand, but they're already in that position for you, and then you ask for the ET to go. If you need to, that's when somebody else could also put their hand where your hand is.
If you're weak like me, just phone a friend and have somebody hold the head. If you say, can you put your hands and put them underneath the head exactly as I'm holding it, so that I only have to hold it for 3 seconds?
Yes.
My arm cannot hold that much weight. It can't. And so I acknowledge that, and I use my people in the room. Use the people in your room so that you can get the best view, because that's the most important part.
The answer to this question is probably having your helper hold the head in that position is going to be way more helpful than cricoid pressure.
Oh, yeah.
When somebody says cricoid pressure, I want to smack their hand.
No, I
Like I really want to smack their hand. Like I just want to go no and like just move on. All right, and so part of this and part of before you should be intubating, you should also be knowing how to use a bag valve mask, right? And how we're holding it. So I never used a PEEP valve until COVID, and then I found that if you didn't use a PEEP valve in COVID, they were literally going to die before you could get the tube in. So I have a PEEP valve on every single bag valve now, ever, regardless. It doesn't matter, because if you need it and you don't have it, you are SOL. Right? The other thing with bag valves is, and it's important, all bag valves have this little thing on it. This is the pressure pop-off valve, right? So if their airway pressure is too high and you're bagging, it will feel easy, right? And if the second you flick this up and that valve is not open anymore, now you're actually meeting their airway resistance and you might be able to deliver the full breath in, but that's when you're just like, holy cow, their lungs are either really stiff or they got a big old pneumo, right? But this is crucial because you'll just be like, oh, I don't understand why the patient's more hypoxic, and it's because you're literally blowing half the volume out of the pop-off valve because their pressures are too high.
And people will just increase the peak valve, like even in the room, people will just increase the peak valve and the think that that's gonna take care of it.
Right, no, so every time when I'm setting up to intubate, I take it and I just flick it up because respiratory therapist doesn't do this. They just leave it down. So I move it up on every single patient. That way, if I'm asking, is it hard to bag, I'm getting a true answer.
Up is closed, right?
Up is closed. The clamp goes over top of the valve. Yeah. All right. So we don't just mash the bag down on the face, right? Like that. You're suffocating them. Right. That's what you're doing. So what you really need to be doing is, everybody talks about the C cup and things like that. You're in a hospital. C cups are made for paramedics, where they're one person bagging in the field. When you're in the hospital, one person is holding the face mask and one person is squeezing the bag. So you should be able to get a two-hand seal. And what you're really looking nope, it's not on this lecture. It's on another one. How you should be doing it is should be cupping basically, and your pinky should be at the angle of their jaw, and you should just be lifting up and displacing the mandible forward with all of your fingers. So like a jaw thrust, right? That's what you're doing. So your thumbs and index fingers are holding the face mask down, and the rest of your three fingers are pulling that mandible forward, and then somebody else is bagging for you. Now, you may need an additional airway, right? Because like we talked about, nobody in this part of New Jersey is 70 kilograms, right? You've got little old mom who's like 5'2" and 150 kilograms, and you're, even with the best move it forward possible, like she's still got a lot of adipose tissue on her neck and other things. So that's when you're looking at your oral airways or your nasal airways. They got to be sedated before you get an oral airway in, or they got to be really obtunded, because the second you try to go and stick an oral airway in somebody who's not obtunded or isn't sedated, like they're going to gag and vomit, and now you got a much bigger problem. So I tend, if I need an airway adjunct, I tend to put two in the nose because they're just easier, faster. Because when you put an oral airway in, you have to put the curve, like flip it upside down so that the curve is at the roof of the mouth, and as you go in, you rotate it down. So if you just try to push it in, what you're going to do is you're just going to push the tongue back, and then you're going to include the airway more. So you got to put it in with the curve towards the roof of the mouth and then rotate it down over. That takes you time and memory, and you have to measure it. And if you just take a biggest nasal airway you can get in and shove it in somebody's nose, it might cause a little bit of trauma, but like it doesn't matter. Yeah. All right. So nasal airways, and like I said, like if the bigger ones, the longer ones will set pretty far down. You just need to make sure that the open hole is towards the septum. The open hole is always towards the septum. So basically, when you're looking at, this is the airway that you would like to see. Maybe a little bit different, but identifying the structures of the airway. So obviously you have the epiglottis. Above that is your vallecula. You have the true vocal cords, and you have the false vocal cords outside of them. You have your arytenoid cartilages, but mainly what you want to see is anytime you're going in for an airway, you want to identify the epiglottis, if you can, the vallecula, and the true vocal cords. And if you're really lucky, you'll see this hyoepiglottic ligament. Basically, this is the holy grail of intubation, because that ligament sets on top of the epiglottis. If you can go in with your Mac blade and just push on that ligament, the ligament shortens and the epiglottis flops open, and you get a beautiful view of the vocal cords. The only way you're going to find this is if you go slow. So the key to intubation is slow is smooth, smooth is fast. The slower you go in and identify all the structures as you're inserting the blade, the smoother it's going to be and the faster you're going to be. What you don't want to do is just ram the thing in and you go too deep, and then you don't understand exactly where you are. You don't understand if you need to come out or if you need to go in. And so you end up with this in, out, and if you just went slow from the beginning, you would have gotten and identified every single structure as you went down. You would have identified what you needed. If you need to go further, you're going further. It's so much harder to back out than it is to go in. So, Mac Miller, I don't know if anybody in our current days uses a Miller. Like, I'm not gonna lie. Like, most everybody I've,
Just
for baby, yeah, for pediatrics, that's really the only time. Most people are gonna be reaching for a Mac because it's easier to set in the vallecula. You don't have to scoop the epiglottis. There are times when you might need it. Like, so there are some people with just really big epiglottises that flop over and obstruct the view no matter what. But if you use a 4 Mac blade and it goes in deep enough, you can just lift it on up with the 4 Mac blade, right? You don't need a Miller blade. So steps is that you gotta place the scope in your left hand, right? Scope goes in your left hand. You scissor the teeth open. You place it into their mouth. If you're using a Mac blade or a Miller blade, you start on the left side, the patient's right side of their mouth, and you move it over to your left because you got to move the tongue up and out of the way. You go in slow, you put your hand on the occiput, you lift it up, and then you're going to get your view. You're going to ask for the tube, or you're going to have somebody hold the head, and then you're going to ask for the tube. So scissor open first. So put your thumb on their lower teeth and put your middle finger on their upper teeth and scissor the mouth open. Remember that you don't rock the tube, you don't rock back, you just lift up and go forward. So generally what I do is I pick a spot on the ceiling. Generally the clock is always in front of you in a room because you're at the head of the bed. There's always a clock. I lift towards the clock. I pick a point out on the wall that's where, like, in front of me, and I lift towards that point. It avoids you from rocking back. So start on the left, and as you see, when they come in here, if they come in directly, you can see, of course, that the tongue is like displaced over both sides. If you start on the left and move it over, you get a better view of the vocal cords. So this is what you're going to see. It's not like big, beautiful vocal cords, right? Like when you're using DL, like it's far away from you, and you're like this. Like it's not like this robust view that you're seeing, right? You're like trying to thread the needle per se. So if you're off angle, it matters. You really need to have them centered up and be on angle. And it's not going to be this robust view. It's going to be like this little teeny tiny thing. If you use video laryngoscopy, it's going to be nice and big, right? So there's a difference between all the blades. So pretty much now we've moved beyond like direct, which used to just be Macintosh and Miller, versus video, which was hyperangulated. Now we have video Macintosh blades. So there's direct versus video, but within video, there's standard geometry, which is like a Macintosh blade, versus hyperangulated or augmented geometry, which is your hyperangulated. With the hyperangulated blade, you just go right down the middle, and you just wrap around the tongue and you lift up. With the Macintosh video, you still need to move the tongue to the left. So, yeah, that's that. They come in different sizes. Generally, 3s are probably adequate for most people. 4s get really big. If the patient's really tall or has a really long neck, that's where you may, or if they're like the big fat biker man, that's maybe where you need a 4 because you have a lot more space to wrap around. 3 is probably okay. I don't know if I ever really care if I have a 3 or 4. I just generally ask for a hyperangulated versus a Mac.
The only reason I usually will get the 3 is just because there's the blueprint difference for the width when you have a patient with a small mouth opening. The 4 takes more space at the mouth opening. So you better have somebody who's going to pull the lip out and make room for you to actually insert a tube. So I usually just do a 3 because I've like never not been able to use a 3.
That's what I'm saying. Like a 3 is fine.
And it's smaller at the mouth, so then you have more space.
Yeah, my default would always be for either a 3 Mac or a 3 hyperangulated, and only in certain scenarios where I'm like, I don't know if this is big enough, would I ever up for a 4.
Yeah. I guess I'm the only one who
Thank God for you because
Now, that being said, if I'm looking through the cart and all I see are 4s, I'm not going to ask for a 3. I'm just going to go for a 4. With the hyperangulated blades, you can't use a normal stylet. You need a rigid stylet. And it's because it is more hooped. So the rigid stylet is going to follow the scoop of the hyperangulated blade. These are a little bit different because you kind of almost have to use it like a joystick. And so you're not holding it like you would a regular ET tube. You kind of more hold it at the top and rotate it with your wrist. When you get it, and how you advance it forward isn't you push it forward, because if you push it forward, the rigid stylet's going to go back, right? So you got to rock back and actually rotate your wrist for the ET tube to advance. That's why because it's a little different. So the first time you do it, you're going to figure it out. It's like driving a car. You don't know how to drive the car. The second you get behind the wheel, you're like, oh, this is how I do it. It's very much like you get this in your hand and you move it around a little bit in there, and you're just like, oh, and you figure it out pretty quick. You do mostly, though, and the big thing is you have to pop the rigid stylet out before once you get to the vocal cord. Sometimes, no matter how you maneuver it, you can't get the tube to go through. You just need to pop the rigid stylet back a little bit to get a little bit more fluidness of the ET tube before you can just advance it forward. That's the only thing. So sometimes I always put like a lid, just a tiny little bit of lube on the rigid like metal stylet portion, just like a little bit to help it slide out easier. Sometimes if the respiratory therapist takes it and they like jam it into the ET tube, it takes a lot of force to pop that rigid stylet, and if it's a difficult airway, and that popping movement may pull the ET tube back, and now you're gonna have to reinsert it to like be able to get back into the position you were. So sometimes just a little bit of gel on it makes it not stick as much, and it makes it a smoother transition out.
Or just like pop a smidge before you go in to like make sure.
Or don't let respiratory load your tube.
I mean, I don't let it. The problem is sometimes they'll give it to you and they'll have done it again. So just double check, because it's like they just like go like this, and it like literally just sits in there.
I mean, sometimes I've almost been like,
I've had some.
like literally let go and like
Yeah.
like pull.
Yeah.
We've all been there. What I would say is, and I'm pretty sure, have we standardized it? No? You should probably start off with video laryngoscopy.
Yes.
Like we're all going to start off with video laryngoscopy, and as we advance, we're probably going to start with video laryngoscopy, and we're going to flip the camera away from you so that you can use a video blade to directly intubate, and then we'll move on to like adjuncts. Like, yeah. So the main con with video laryngoscopy is that it's a camera. So if they have a lot of blood or secretions or things like that, it gets on the camera. And the second that it gets on the camera, you have a blurred view. And the only way to clear that view is to pull it out and wipe off the camera. So there's grade 1, which is big and beautiful. There's grade 4, which is basically you're guessing if you're intubating the cords or the esophagus. And there's some sort of degree in the middle. In general, you always want a grade 1 view. And using video up front also helps us see what you're seeing, as opposed to us trying to look over your shoulder, like how I learned, and I wasn't certain if they were seeing what I was seeing, if what I was seeing was true. Bougies, you can either load it like this, which is not how you would do it. Mainly you would do it like either cued or stuck in the tip. Bougies don't work with hyperangulated blades. They only work with Max or Millers, because a hyperangulated blade is theoretically the most anterior you're ever going to get, and you're never going to be able to cue the bougie with more of a bend than what the hyperangulated blade already has. The tip of the bougie is flicked up, which gives you that last little bit of oomph in case they're super duper anterior and you're getting kind of a view, and you just need to like get something up and in that you just can't physically lift or maneuver around. So with the bougie, you'll feel the tracheal rings like click, click, click. So sometimes anesthesia will intubate a grade 4 view. They'll intubate this with a bougie, and they'll feel for the tracheal rings. And when they feel the click, 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 they know the bougie's in, regardless if they got their view or not. I would not recommend that. If it won't advance, what you basically do is you draw circles with the bougie, or do a figure 8, and it should come off of whatever ring it's held up.
If you're understanding the anatomy, right, like you just turn to the right, now you take the ring, you're not going to advance it. You turn it to your right, now it's straight, and then you can advance it.
Yeah.
Same with the rigid stylet. You'll see a lot of times if you're getting those tracheal rings, you just turn to your right. The anatomy is just if you were going like this, turn to your right, now it's straight, and you can advance, and then you can pull it down.
Everybody's got these failed airway algorithms. In general, it's one intubation. You better change what you did the first time, because redoing what you did that just failed doesn't make any sense. The third go should probably go to the most experienced operator in the room, whether that's you or anesthesia or the intensivist. Like if there's an attending on, like that's how it should go. And if you fail 2 or 3 times, or the patient ever desats, it's an immediate surgical airway. So like where we get in trouble is when we go, I go in and look, and then I go in and I look either the same way or I look a different way, but I didn't change that much. And then anesthesia goes in and they can't see it. And then the other anesthesiologist goes in and they can't see it. And then the patient codes from hypoxia, right? Like you very clearly, it's like 1 potato, 2 potato, 3 potato cut. Like that's how it works. So I don't like, and so there's a bunch of algorithms that have arrows of this and that, but in general, it's you fail once, you better retry something different, like incredibly different. Like
I'm recognizing that it's not just hypoxemia that a patient would then have an arrest from. It may be hypercapnia.
Yeah.
Keeping in mind that a patient who is metabolically complex, like we talked about that terrible intubation, in this case, the failure to be able to ventilate these patients during a period of multiple attempts is another way that they can code during this event. So recognizing that they need to be able to, you need to either do face mask, with adequate ventilation and oxygenation in the interim of these attempts, or you need to put in, I'm sure we'll go through another rescue device, an LMA, which again is a temporary device, but may buy you time to be able to get more experienced operators, other teammates in the room, other equipment in the room. So it's all about, again, creating any time you can take a chaotic situation and create both space and time for appropriate decision making. You've done the right thing by the patient, and you can often temporize with these measures. But I 100% agree that it's about like making sure that the algorithm isn't this patient codes, and that's like before you're recognizing that this is a surgical emergency.
Yeah, and knowing what your reserve is, right? If somebody is setting 100% and their PA2 is like 400 because you have them on high flow, it will take them like 4 minutes before they actually fall far enough down on the oxygenation to like the curve to actually become hypoxic. Somebody that's setting 100% but their PA2 is only 85, it takes them less. Somebody that's setting 90, you've got seconds before they fall off a cliff, right? So understanding where you are on that curve buys you time. Also, in terms of pH, right? Somebody can be altered and, they're hypercapnic, but they're just hypercapnic enough to give them a pH of like 7.2, right? There's the DK air that comes in at 6.8 and is breathing like a freight train. And the second you push the etomidate and rock and they're not breathing like a freight train, they cannot compensate anymore. And then you have, if it takes you more than one attempt to go in and get that tube to hook them up or bag them with the bag as fast as that they were going, their pH is no longer 6.8, it's 6.5 and they code. Right? So understanding where you are when you're going for all these things also ups your attempts, because then like the DK air who just is obtunded because, or like hypoxic because they just can't keep up their drive anymore, right? My algorithm for them is if I don't get it, we're cutting, right? It's like one pass and then go, right? It's not like we're going to re-attempt, or it may be like Lindsay was saying, like it's an LMA to bag, and then some of the LMAs you can like put your stylet down through and like almost intubate through the LMA. Like you can bougie down through it and then pull the LMA and then railroad the tube over, right? There are some patients that just need that. But that goes into patient selection, right? Before you intubate, you got to select your patient, right? Is this appropriate? Some DKers, even if their pH is 6.7, if they're breathing like a freight train, the ventilator can never do what that patient is doing on by themselves. So as long as they're compensating, do other things and fix the DKA to make them less metabolically acidotic, and you will fix their breathing. So patient selection is key. This is just showing more advanced algorithms and then LMAs. So I think most of the ones we don't have Kings. I've only ever seen the eye gels. So
EMS here was well.
Yeah, I do get one.
But these are basically like if you're like, let's say sometimes you're waiting on, for whatever reason, you may be waiting on a ventilator, you may be waiting on respiratory, and you don't have time to wait before you're going. Sometimes you can just drop an LMA in and start bagging the LMA and buy yourself time before you have to go. Or if it's like Big Fat Biker Man and you're terrified of intubating and anesthesia is taking forever and you can't wait anymore, you can put the LMA in and oxygenate and ventilate through an LMA while you're waiting on the more experienced provider or quote unquote the airway expert. The other thing is, and it's been proven, when medics intubate somebody in the field in cardiac arrest, no study has ever been shown that intubation in the field or intubation during a code has ever been superior to LMAs, ever. So if somebody's coding and you're the only one there, and anesthesia is not coming, you can literally put the LMA in, have somebody with a respiratory bag through the LMA and run the code. And when you get ROSC, then intubate, right? Like if you're in these situations where you're literally the only one and there's no other provider, you don't need an advanced airway. You just need an airway. And LMAs give you an airway. Questions? We'll just rock it through chest tubes really quick, and then what we're going to do is we're going to split. Half of us are going to do chest tubes, half of us are going to go intubate. We're going to do that for a little while, and then we're going to switch. So we're going to do standard blades with standard like intubations, and the glide scope is in there for you to practice on with max and hyperangulateds and bougies. The mannequin in there, Apollo, is a little bit more difficult to intubate, and we'll move this guy next door for the direct intubations. And then we'll go through the chest tube. We'll go through the central line kits that we have here just for you to familiar yourself with them. If you want to put in a central line, you can. I assume that most of us have done that by this point in time. If not, we can go through it. And then we'll do some percutaneous chest tubes on this guy here. And then I have my own ragtag rigmarole surgical chest tube box. So we'll do those. All right. What?
And also you guys will learn patient flow.
Yeah, we didn't, because we didn't want to there's only so much time, but you'll definitely,
Yes.
It can be hooked up to the.
just
Yes.
for the nature of time.
Yeah.
There's a lot of.
I have to have an advanced airway
There has to
sound.
be-
So I guess,
there has to be
like.
separate- yeah, it's a lot.
Chest tube there.
This is just boot camp, it's not all of fellowship in 3 days.
Here we go. All right.
I have a quick question.
Yeah.
On nights, let's say, if we have a patient that needs to intubate, I'm guessing anesthesia, is anesthesia in-house?
Mhm.
No.
So in the until you are very comfortable with
We'll
intubating,
determine with you.
which
Like,
yeah,
we're independently determining.
yes,
Okay.
yes,
Just so you know, from a fellowship perspective.
you would call anesthesia. Most times at night you're gonna get the CRNA. The anesthesiologist is here, but they don't come. The CRNA comes. Some of them are nicer than others. Most of them, at least it's like a 50-50. Most of them will like let you intubate and just stand there beside you, and give it a go. And the other half will say, no, you called me, I'm putting the airway in. Until we determined and we get you guys comfortable to do it, that's just kind of how it goes.
Like some of them will have a policy, like if you are calling them, then they are doing the airway, which is like a very reasonable thing, honestly.
Yeah.
Because that is what we are asking them to do. And so we would have you start with your airway management during days like when you have an attending present who can actually be supervising you, guiding you through, and then you will get to a shared place where like our team and you will both feel comfortable with airway management.
And even then, most of our anesthesiologists are comfortable. If you're just calling them just to stand there and watch you debate, yeah, that's perfectly fine.
Which then that would be like sort of the next phase. Like at first, right now, like if you're, on nights like in a week from now, you're gonna call anesthesia and you are just gonna be like present. Like you're like here, I called them, but especially during a period of extremis, this isn't something where you're like, oh, this person's gonna be in today, like within the next couple hours. It's like you're calling them because you need them right now. My advice would be like be present, see how they do it. That's like number one. And then it'll be, with our team and having, some like shared comfort on kind of how comfortable you'll be moving forward. And then even off hours, if we are not present, my recommendation would be to call anesthesia and then just say, hey, is it okay? I'm going to do this one. I have experience, but still having them next to you. And that's again to protect you. Like you shouldn't be like 3 weeks in just intubating people without anyone else around for your own benefit.
Same thing with chest